And so our next lecture will be coming today from Dr. Burton Brodsky. Dr. Brodsky is an obstetrical and gynecologic specialist practicing in Perrysburg, Ohio. Dr. Brodsky received his medical degree from Wayne State School of Medicine and completed his residency in the William Beaumont Army Medical Center. He currently lives as the director of minimally invasive surgery, section chief of gynecologic services, and assistant clinical professors at the University of Toledo. Dr. Brodsky has earned multiple national teaching awards and is an active member in community service on Partners Board for the Karmanos Cancer Institute. His special interests include robotic minimally invasive surgery and urogynecology, and his research interests also include hereditary genetics and clinical research. Please welcome Dr. Brodsky as he presents his lecture, Hereditary Cancer Prevention, What Your Patients Want You to Know.
Next slide. So this is one of my favorite pictures. This is a picture that people think is my wife and my son, but it's absolutely not. It's a picture of a friend of ours who I met about 17 years ago. And she wrote a book on this, and it's called The Best of Times. It's a really cute picture. That's her son, Hayden, and I have a son, Braden. They were born around the same time. So I'm going to tell you Lori's story real quick. We met Lori when she moved in our neighborhood, and she'd asked me if I did a lot of that BRAC testing. She knew I did that testing, and at the time, that was all that was out there, and if she would be a candidate for BRAC testing. And I said, normally when I meet people for the first time, I don't ask their family history. So she told me, well, when Lori was 16, her mom died of ovarian cancer. So if I knew nothing else about Lori right now, her risk to carry a gene would be about 8 to 10%. Lori was 34 years old at this time. And when you realize this is your highest risk patient you're going to see in your practice, there's no cancer you could come even close to this 8 to 10% risk. And that's not that she has a risk for cancer, that's a risk to carry a gene. She said, that's the good side of my family. Not to mention that Lori's Jewish, and now it's not 8%, it's about 40% risk that she carries a gene. On her dad's side, there were 3 breast cancers, an ovarian cancer, and a male chest wall tumor. So I'm not great at statistics, but now her risk is like 190% to carry the gene. So I tell Lori, yes, this is something you should be tested for. She goes to talk to her physician, and her physician's like, Lori, you're trying to have kids right now. I would wait. So this happens all the time. She does wait. Hadn't been pregnant in a year, so she went to see an infertility specialist. And if there's any infertility specialists here, when you go there, you get ultrasounds every 3-4 hours. So they know that her ovaries were normal size, but she was complaining of bloating, cramping. She was on Clomid. She gets pregnant her 2nd month of IUI, which is incredible. Gets pregnant, it's great. When she's pregnant, if you don't know this, your bowels slow down when you're pregnant. So she was constipated, had some complaints, but normal complaints of pregnancy, and she delivers. And I think about when my wife had our first baby, he was 9'8". If you haven't seen a 9-pound, 8-ounce baby, they're usually not the cutest. They're kind of swollen, a lot of fluid. And she held him up and she's like, I've never been more in love in my life. Now, as a guy, you're kind of taken back a little bit as you're standing there. Then my wife said to me, when I met you, did I clean out a room, get new hardwoods, get a new bed for you, get new clothes for you? And then you think about it, and pregnancy and newborn's the greatest thing ever, right? So then I go through Lori's story, and Lori delivers little Hayden. We had Braden at the same time. And here's her experience. So she delivers. She's still a little constipated, goes back to the office, 6 weeks visit, doing great, but she's still bloated, constipated. They said, your uterus, it's bigger, pushed on her, said, come back in a couple months and we'll see what's going on. It'll probably all fine. Okay, pretty fair. She comes back in 3 months. Her belly has fluid everywhere, omental caking, ascites, and she has stage 4 ovarian cancer. So that newborn feeling that you had trying to get the car seat in and breastfeeding and is the greatest ever kind of goes away really quick. And Lori was told, she met with the GYN oncologist. It was great. They got her in a day or two later. She was told there's a 90% chance that you're going to die in 5 years. And the good news for Lori is she's a survivor. If you make it 5 years, you're a survivor. And Lori made it 5.5 years. And if you think that's a survivor, you're kidding yourself. She had 3 laparotomies for bowel obstruction. She had a home NG tube for the last 10 months of her life. At her survivor party, she had an NG tube in. I got to tell you, that's not a survivor. And she went through a ton of different things. We talked about this. She wrote a book on it. And talking to her and asking her what was the hardest thing, she's like, oh, the hardest thing by far. Losing my hair I could deal with, surgery I could deal with, being away from my family was super hard, but knowing you're not going to see your family grow up. And I remember Hayden was 2.5 because Braden was around the same age, and she brought over Hayden. She's like, do you guys mind watching? We had 3 kids. I said, no, it's not a problem. She's like, we're just going to do a little shopping. I'm like, oh, awesome. So when someone says that, what do you say? What are you shopping for? And she's like, we're going to pick up a wedding gift, a graduation gift for him. Hayden is 2.5 years old, and she knew she wasn't going to be around. So these are the people. Now, again, you can't say you'd make a difference for Lori. Her biggest regret is that someone decided this for her, and she didn't get to make this decision. So all of us have a Lori in your practice that you see every day that's in and out of your office. Again, I now follow about 500 to 600 BRCA positive families, about 400 Lynch positive families, multiple other mutations since we've been doing panel gene testing. I've had about 15 fallopian tube carcinoma in situ and 4 stage 1 ovarian cancers. And I got to be honest with you, I always tell people, if I diagnose your ovarian cancer, you're probably stage 3 or stage 4. We haven't changed survival from ovarian cancer since 1970 by more than 5%. 5-year survival is about 40% now. It was about 36, 37. We haven't done a great job with that. Breast cancer, we've done an awesome job. We have screening. It went from about 50%. Now it's about 90% 5-year survival. That means only 10% of people die from their breast cancer. So that's fantastic. But just realize that you have Loris in your practice that come in and out every day, and we can do something about it. These are the people you make a difference in their life. Next slide. You can skip to the next slide. Well, I'll just go through this real quick. My talk's called Prevention, what you and your patients want and deserve. It's not called genetics. As soon as you say genetics to people, they get scared, right? It's prevention. That's why people come see us, because they want the prevention. I've never had a female, I've been in practice 23 years, who comes to see me who wants their pap smear done. If you come to see me, you're like, I'm excited for my pap smear day. I walk you to your car with your chart. You can pick whatever color ribbon you want, bow for your chart, because I'm not seeing you, right? People come in because they want the prevention. So I hear all the time my patients don't want to know this. They do want to know this. They wouldn't be in your office, and I'll kind of hit on that later as well. But if you kind of normalize this, and this is kind of what really made a big difference. I've been doing this in my office for 20 years now, as far as testing, and I've never been ahead of the curve on anything. If I have to prove to you I'm not that bright, me and my wife had 3 kids in 26 months, and I think that kind of solidifies everything. But here's what I'm going to tell you. If you regulate this to how we do things and normalize this to how we do things now, right? If someone comes in, a 36-year-old comes in with low-grade HV positive, we don't tell them to think about a colposcopy. No one says, here's a brochure on colposcopy. Go home, talk to your significant other. If you think you want this done, come back and see me, right? That sounds crazy. No one does that. And I've asked people, why don't we do that? Well, because their screening test came back abnormal, so we have to do a diagnostic test. Sure, that's great. So that's what we do. That person's risk for cancer, if we did nothing, is way less than 1%. Way less than 1%. If she misses 3 appointments, we send her a registered letter. We can't see in the practice anymore. You didn't follow up, right? If a lady comes in with a family history, your mom had breast cancer at 46, right? She's doing great now. She's 68, she's 70. Her risk is 8 to 10%. It's not way less than 1% to carry a gene that's a dominant gene that affects her and her family. And again, I can do this with abnormal mammogram, BI-RADS 4 mammogram. Nationally, I was at the Orlando Cancer Center just recently. It's about a year and a half ago. Their risk for a BI-RADS 4 mammogram is about 10% for cancer. That's the same risk if you've had 1 ovarian cancer in your family. My grandma died last year at 106. If she had that, that'd be the same risk. So I got to tell you, I'm super lucky. I don't have a family history of cancer. I just told you my grandma was 106. My great-grandma lived to be 99, as did my other grandma. That's wonderful. The women do great. So I don't have a family history of cancer. This just made sense to me. And I'm at a higher risk because I'm half Catholic and half Jewish. That's called a cashew, if you people didn't know that. But that puts me at higher risk as well. I do this because it makes sense to patients. So if you think of BI-RADS 4 mammogram and someone with a family history, the family history is much higher. It's a much higher risk. And you can do this with postmenopausal bleeding, ovarian masses. There's nothing that's close. When I did the ACOG talk about 4 years ago in Chicago, I had a G1 oncologist that came in and said, only 2 things that are close are complex hyperplasia with atypia and recurrent adenocarcinoma in situ. And I said, so what's the risk of those? He's like 30%. Okay, and they're not dominant, so they're not passed on as well. So there is nothing that's even close. And I get about 13 to 15 cases sent to me a year where someone's done the wrong surgery. And I don't know about you guys, but I don't want my wife having any inappropriate surgery. And I'll go through these with you so you kind of pick up on that, just so it makes sense. So next slide. You can skip this. Next slide. Keep going. Just till all the bullets come down. So the conclusion is, I just want you to understand how you look at someone's family history. Just remember, someone's family history, that's what the screening test is, right? You give me your family history, it comes back abnormal, we need to act on that. If I don't have your past medical history, I'm not going to treat you with hormones. If I don't have your past surgical history, take you to the OR, I'm going to tell you their past family history is as important, if not more. And I asked two people, I just asked you two questions, right? Anyone here have time for cancer right now? I've never had someone say, yeah, I have time for cancer right now. No, it's never happened. And if there was one thing I could do for you and your family right now to decrease your cancer risk, would you want it done? And the answer is yes. So again, understanding family history, how to stratify people by risk, how to integrate this in your practice, and how technology works, again, using gene panels so we can certainly further benefit patients and families. Next. So these are common gaps in patient care. So basically, these are excuses that I've heard over the past 18 to 20 years why people don't do this. So time consuming. I asked you right now, does anyone here have time for cancer? And they're like, no, we don't. Your patients don't as well. Take the time. I do minimally invasive. I'm head of GYN. So if someone sends me a patient, she's usually around 460 pounds. She's had 7 C-sections, her appendix out twice. Oh, and only PID once, right? So if I can have someone who comes in who's normal size, and I can do risk reducing surgery and make a huge difference in them, or get them in a high risk protocol, just improving their surveillance, that's fantastic. So again, as far as time, yeah, does it take a little more time when someone comes in with that? Of course it does. This is cancer prevention. If you don't believe in this, I would tell you stop doing pap smears, breast exams, belly exams by manuals. What are we looking for? Masses, cancer. Not testing the same day. We're too busy. We don't have time to test. Have too many quality metrics to deal with right now. Again, nice to know versus need to know. This is not a nice to know. If I don't have this, I can't treat you. This is a vital sign to me. If this comes back, it's positive, it's going to change your management for sure. So to me, if I don't have this, it's really hard to take care of you. I refer out to the GCs. I can go through that. The models are just hard. And again, I've seen this before where it doesn't work out. The goal is that patients get the information. That's my goal. That's your patient's goal. We all have the same goal. I'm just telling you from a model standpoint, the best I've seen follow-up wise has been 25%. So if you thought about in your office, if all your screening tests for years said pap smears, NSTs, lab results we do, right? Obviously mammograms, things like that. If we took only 25% of those and the other 75% we threw out in your office, you'd never do that. That's crazy. That's essentially what we're doing. So we have to do a better job with it. It's not my responsibility. It's one of my favorites. If you're seeing my wife and she comes in, this is her history, of course it's your responsibility. Next slide. Proactive versus reactive. Again, it sounds contrite, but if you're reactive, people die from cancer, right? We'd like to be proactive with our health. Patients would like to be proactive. Cost of testing comes up all the time. Last year, nationally, the cost of this test out of pocket was less than $50. So again, I don't do my finances. I'm not doing my patient's finances. But again, that makes a huge difference. But you tell them this. And again, most of the companies now will call with anything out of pocket. A penny out of pocket, they call them, they work with them. They're great programs for patients who are uninsured, low-income patients. It's great. I didn't learn this during my residency, during my training. I hear that a lot. I didn't learn robotics, urogynecology. There's a lot of things I didn't learn, right? Cell-free DNA wasn't around back then, but obviously we adapt, we change. Texting the index patient's great, but again, it's very hard to do. Informed consent. So it's a better informed consent because the patient signs it about twice. We go through it as well. What's in it for me? I love my patients don't want to know, right? Patients like, oh, I wouldn't want to know. And I think about this, if this is a dominant gene, you could pass this on to your kids, right? 50% chance. I'm not great at that. 50% chance you pass this on to your kids. Of course, there's nothing you wouldn't do for your kids, right? Plus, it's going to change your management. I told them, you know, you have a terrible family history of breast cancer or colon cancer. If we had a better mammogram, would you want it? Well, of course I would. That's what this is, right? And I can go through that with them in numbers. I've only had 2 patients. We only had 1 patient who didn't test. And she said, if God wanted me to have this, and I don't have the God talk, I was fine. Other than that, almost all my 99.9% of my patients have done this once we're educated, right? My goal is not to make decisions for my patients. It's to educate them, give them the information, let them make their own decision. I can't find patients that meet testing criteria. That's easy. I use the family history questionnaire, which I think everyone should, and I'll tell you as to why. And it's listed right there. Here's the National Comprehensive Cancer Network criteria. That's NCCN. That's what I use in my office. You hit yes, we test. I was down in Louisiana. They said 1 and done. Perfect. Love it. Next slide. So I've given them so much information, it's overwhelming them. It's so complicated. So complicated, it's not me giving you all this information. Here's brochures on this and this. Complicated is looking someone in the eye, tell them they have ovarian cancer, tell them that you're a medical oncologist, surgical oncologist. We can't treat this. We haven't gone through any really very mild improvement changes since 1970. And there's a 90% chance you're going to die in 5 years. 90% chance you're going to die in 5 years. That's overwhelming to someone. Try that. Look someone in the eye and tell them that. Yes, that's one thing. We just had someone who was stage 4 rectal carcinoma who we were working up for a mass. She was waiting on a test result that she'd seen about 4 other people for. She perforated this. It was colorectal cancer. She was 36. It spread to her ovaries. And yeah, she was Lynch positive. We found after the fact. She'd seen about 5 other providers. So again, I don't feel comfortable talking about genetics. We talk about genetics every day. If you do OB, obviously we talk about genetics. Recurrent pregnancy loss, we talk about that. Thrombophilias, we talk about that. So genetics is part of what we do, and it's going to be the wave of the future as well. I've tested all my patients already. Again, one of my favorites. No one's family history gets better. It only gets worse, right? If your grandma died from breast cancer, it doesn't improve your family history. It's unfortunate that she passed. That's what it is. I don't know what to do with the results. That's a nice thing. Now, again, you get the results. The NCCN criteria are listed on the results, which is great. It tells you what to do. Did I know what to do before 2014 or 15 for RAD51C or D or BRIP or no? Most of us didn't whatsoever. They're newly found genes. So again, now that they list the NCCN on most of the results you get, that's very easy to take care of. It's only one family member isn't going to change anything. It only takes one family member. And this is the big one again. I'm concerned about liability. If you're concerned about liability and you're identifying your highest risk patients and doing nothing with them, you should be concerned about liability. To me, it's just the opposite. You identify patients who are at risk and you treat them appropriately. That's what we do. So next slide. So impact of genetic disease. So 5 to 10% of cancer is supposed to be related to a gene. And I like this, 1 out of 4. They think 25% of patients that walk in our office, this was done by Dr. Mark DeFrancesco, past president of ACOG. I met with him. We've talked about this before. And again, a lot of times when people start doing this, they're kind of hesitant. Obviously, it's something new. It's actually not that new. That's the crazy thing. It's been out since 1998. So in his office, is about 25% of people, I should say, through his system, we're at risk. 25%. We usually say it's about 10 to 15%, but 25% is huge. That's 1 out of 4 people that walk in. You're making a difference in them and their family's life. And again, about 60 to 70% of those patients are going to be altered by the result of that. And I'll go through that. Next slide, please. So sheer numbers, if you look at breast cancer, 12 to 14% are hereditary, ovarian is about 24, uterus and colon are about 10. So if we can eliminate that, look at the number of patients with hereditary cancer on the side. And now you're talking about families. Right, my family, there's 25 in there. So if I'm identified, that's going to affect 25. So you can add that number, think about the multitude of that. Obviously, it's much higher. And I've heard people say it's only 25%. If it's ovarian cancer in my family, we could do something about this. Risk reduction, absolutely. You got to remember, these patients have seen their families die. They didn't meet uncles, aunts, anything along the way. They want everything done. The patients who are positive for the gene are my easiest patients to take care of. They're beyond compliant. They know exactly what they're going to do. I don't have to worry about them missing a colonoscopy or missing a breast MRI. Not a chance. So next slide, please. You can go all the way down to the slides. Done, please. That's good right there. It's fine. So I'm going to give you 3 clinical cases real quick and go through this with you. This is a 39-year-old abnormal bleeding, failed ablation. She's one of my OR techs. She comes to see me. She's like, I want surgery. She knows I operate Tuesdays, Fridays. I want 2 weeks from now. Okay. So again, before I get her history, because a lot of people won't ask her family history because she's not an annual exam. I've heard that before. Again, we'll get through that too. What test would you order? So she comes in. Here's her family history. She was boarded for a hysterectomy. Again, this is about 9 years ago. They were leaving her tubes and ovaries, just taking her uterus. Okay, first of all, she had a failed ablation. Her uterus was about 12 weeks in size. The doctor she was seeing didn't do minimally invasive. They were going to make an open incision. She knew I did robotics, laparoscopic. Great. All right, so what test would I order when boarding this patient? Would you take her tubes and ovaries? Most people say they take her tubes now, but not her ovaries. But then we look at her family history. Mom's breast cancer, 52. Sister ovarian cancer, 29, on home hospice. Dad had colon cancer, 49. She told me your uncle had a belly tumor. That's a lot of times that's the history you get, belly tumor. I don't know what that is. I'm assuming it's gastric, but we don't really know. So again, I test her for BRCA, and is she positive or negative? Obviously, we're speaking about that, so she's negative. She's negative. She is negative. She's positive for Lynch. She's Lynch positive, so someone did an ablation on her. First of all, we could question that for a 12-week size uterus, but forget about that. We do an ablation on someone. Again, her risk for uterine cancer, if I asked you right now, would you do an ablation on someone who had a 29% risk, complex hyperplasia with atypia, you'd look at me like I was crazy. You would never do that, right? Her risk is 71% risk right now, 71% risk for uterine cancer. Do you think she's a good candidate for an ablation? No, she had an unnecessary surgery. She was scheduled to leave her tubes and ovaries in, which we don't want to do. Her risk is about 12% for ovarian cancer that peaks at age 41. Not great. You could look at this history alone and say her sister had ovarian cancer at 29, 1 first-year relative, 2 secondary relatives, SGO, ACOG. You can consider taking their ovaries out right there. Well documented, haven't had a problem with that as well. From an insurance standpoint, more importantly, it's great care for the patient. So you can see how that'd make a huge change for her. We waited for a test. She wasn't super happy, but we took her tubes and ovaries, and she's doing well. She has 1 daughter, so obviously it makes a huge difference for her. More importantly, it makes a huge difference for her family down the line. She had 7 brothers and sisters. A few were positive, others were negative. Next slide. This is just a patient of mine. This is my second fallopian tube carcinoma in situ. This patient came in, Sherry. Mom had breast cancer at 41. This is one of the ones that really told me that I was a bad doctor. A lot of other cases as well tell me that. But here's one because she was 46. Mom had breast cancer at 41. We test her. She comes back to the office. She's positive for the BRCA1 gene. I go through breast cancer, ovarian cancer, go through all this stuff with her. She's like, I don't want to do anything with this. I don't even want to do screening with it. I'm like, we did this test for a reason. We kind of go through this. She's with her sister. Her sister's, we should have never done this. I'm like, she's positive. Like, we did a great thing for her, right? She waits, goes down. Family friend is dying of ovarian cancer with a HOMAG tube in. This is about almost 9 months later. Comes back. He's like, I want my ovaries out. So after all my great explaining, everything else that I do so well in my office, it took her to see someone who was dying for ovarian cancer before she understood it. And sometimes that's it, and you just need to see something tangible. Okay, that's what it is, great. So she decides she wants to do that. We're in pre-op. She's like, I can't do it. I want to keep my ovaries and tubes, and she cancels her surgery. So now I'm mad for 2 reasons. I had this scheduled for the day, and she's not getting great care. So we go back about 8 months after that. She's now been almost 2 years. She decides she wants to get them out now, and it's important for her. We take her ovaries and tubes out. She says she wants to leave her uterus. Great, she's BRCA1. There's evidence to say taking the uterus. We can go through that. But we take her tubes and ovaries. Pre-op, she's like, I want to leave my uterus. Fine, that's great. Leave her uterus, tubes and ovaries, and I get a call that she's fallopian tube carcinoma in situ. And I bring her back to the office, and she is cracking up laughing. And I'm thinking, we got so lucky. You got so lucky with this. We did this at the right time. Here's what happened. Here's follow-up. We ended up going back and taking her uterus, talked to my GYN oncologist, and she came back negative. Her sister came back positive as well. She waited until she got breast cancer. She wasn't a patient of mine. Anyway, she's cackling, laughing in my office. And I was like, what is so funny? And people respond differently to this. And she told me, Doc, I told you we did this at the right time. And she waited almost 2 years and got super lucky. And I don't know how it is in Georgia or different areas you guys are from, but you can't choke out patients. But if we could have, and I didn't use my card, that was one of the most maddening things that had happened. But it all worked out good for her, and that's great. But she was one of my 15, 16 fallopian tube carcinoma in situ. So you can see what a huge difference this makes with just one family member. Next slide. This is another case, and I just bring this up because this is a patient who's Jewish. My percent Jewish in my office is about 1%. Mom had breast cancer, BRCA negative. Oh, great. We don't need to test her, but you can see she had 3 aunts, a grandma, dad with colon, uncle with colon. She came back, checked 2, increased risk of colon and breast. So when you see these family histories that just light up the board like Las Vegas lights, right, we may not have that gene as of yet, but there's probably something coming. So she was one of the ones, well, why do I need to be tested? My mom's BRCA negative, because there's about 11 other genes that increase your risk for breast cancer. Next slide. So risk reducing BSO is recommended after childbearing, preferably age 40. And again, depends if you're BRCA1, BRCA2, and if you're Lynch positive as well. And the numbers will be right in front of you. They're given to you, which is great. Removal of both ovaries, fallopian tubes to the level of the cornua, ligation of the vessels at the brim. Again, do washings, look at the cavity as well. The difference is they look at serial sectioning of this, and instead of cutting 1 centimeter section, so you think a 3 by 4 centimeter over, they cut 3 or 4 times. They cut millimeters. That's probably why I pick up a higher number, but the number is 2 to 26%. I've had like 15, 16, I don't know numbers wise anymore, but that's huge. And you make a huge difference in these people's lives and their families' lives. Next slide. So when I look at risk stratification, you can look at it orange. The orange is when you get a positive. They come back positive, they're the hereditary risk. Obviously, that's the highest risk. It's a dominant transmission at that point. You need to test their family as well. So those are highest risk patients. Those are patients I told you, that's like cookbook. They come in, they're positive for, PMS2, and they have Lynch Syndrome. Here's what to do for the colon. Here's what to do for, and it's just listed right in front of you. Great. Brad51 CD, perfect. Those are patients. They follow up. They know exactly what they're going through, testing their family. If you look at that gray area there, that's a general population risk. That's wonderful, especially if those are your patients who are true negatives. We know the family's dad's positive, you're negative. That's great. You're the general population risk. We can treat those patients just by chance, right? They can still get cancer, but it's low. And that familial moderate risk, blue, has actually grown since you look at this pie chart here. Again, other patients we do, about 30 to 50% come back positive. I'd say probably about 40 or 60% now come positive, meaning they don't carry a gene, but they're still a high-risk negative. So ASCO, American Cancer Society, American Cancer Society will tell you if their lifetime risk for breast cancer is over 20%, they meet criteria for breast MRI, tamoxifen, other hormonal manipulation, BSO, and we talked to them about that. For that matter, bilateral mastectomy as well. Again, so those patients still need to be acted upon because they're high-risk negatives. Next slide. I'm going to skip this. So if you look at the general population risk, look at breast cancer. So obviously the orange we're going to keep with the same numbers. The blue is the familial, and that's the general population risk. Breast cancer by age 70. So it's about 14% compared to the familial one I've seen as high as about 48%, I think 52%. But look at the hereditary risk, 87%. So every time you go for screening, there's a 13% chance it's not going to come back cancer. So you want to talk about like anxiety and fear? Yeah, every time I went in, I think that's not great odds. I'd want to do something differently, and you would do something differently. But look at ovarian cancer, right? 71% compared to 4 to 11% compared to as high as 63%. Huge difference. And again, remember, morbidity, mortality is the highest for any GYN cancer we have. It's for ovarian. Second, breast cancer. This is the other thing. When I had breast cancer, if you're positive, recurrence rates are about 2 out of 3 people get recurrences by age 70, usually within 10 years. So you have to manage these patients. And again, if you do lumpectomy with radiation before these patients, it's very hard to go back and do bilateral mastectomy after that. And again, the breast surgeons I work with, they won't do it. They won't operate on you until they know the status, because it makes a difference for what they would do. It makes a difference for their patients and outcome. Next slide. So this is for Lynch syndrome as well. And you look at colon cancer, 82%. Again, I'm looking at the orange here. Endometrial cancer, 71%. The previous slide for ovarian cancer, it's okay. For the previous slide for ovarian cancer, we do risk-reducing surgery, even if you come back negative for the gene, because the risk is so high, we have no screening for ovarian cancer. There is zero screening for ovarian cancer, please. So looking at endometrial cancer, 71%. We do not do risk-reducing surgery for a family history of uterine cancer. Most people bleed, 98% will bleed, have symptoms. We can follow that. We have screening. So we don't do that. For ovarian cancer, of course we do. And look at the numbers there. Ovarian cancer by age 70, 4 to 11%, depending what gene, based on family history, why we do risk-reducing surgery with no screening, and 12%. The key with Lynch syndrome, it peaks at about age 41. So you don't want to wait till they're 40 or 45. You want to do it much younger. Next slide. So again, this is just showing you the difference. Looking at BRCA 1 and 2, if you look at the slide on your left, now we're looking at P10, ATM, PALB2, CHEK2. Yeah, we're looking at a lot more genes. So obviously, if you just widen that, we just take it, spread that out wider, it makes a huge sense that we're going to pick up more, right? Now we're looking at breast, ovarian, gastric, colorectal, pancreatic, melanoma, prostate, and endometrial. Next slide. So obviously panel testing, which we started 2014-15, the American College, again, supports that. You'll pick up about 2 times the mutations. That makes sense. My sister's an interior designer, and that made sense to her. You're looking at more genes, you'll pick up more. Next slide. So I want to go through the ACOG criteria with you now. The embarrassing part for me here, and this has gotten me in trouble 3 times, Dr. Jennings, Dr. Kirkpatrick, Dr. DeFrancesco, because the gene comes out in 1998. Our American College comes out with their first statement 11 years later. There's probably someone from ACOG here. If you feel like yelling at me afterwards, it's fine. So, and here's what they put: evaluating a patient's risk for hereditary breast and ovarian cancer should be a routine part of the OB/GYN exam. All right, so it should be a routine part. They don't say consider it, think about it, possibly hand out a brochure. No, they tell you it should be a routine part of what we do. They also said in this first bulletin that consider testing for an 8 to 10% risk. Consider testing for an 8 to 10% risk. I was in Denver with Dr. Kirkpatrick, and I said, that's like counting out a mammogram slip. We used to do 35, the American College of Surgery, then 40. You know, they want to push it back to 50. They want to push it back to 50. Do you know what the risk for breast cancer is, the general population by age 50? It's 2%. So I said, let's not even give mammogram slips out at 50. Let's wait till they're 70. That's when it hits the 10%, 8 to 10%. We'll hand them out there. And he stood up in the meeting. He's like, I'm Dr. Kirkpatrick, president of ACOG. I was the president of ACOG when this was going on. And I was like, awesome. Like 3 slides in, I insulted the past president of ACOG. It was great. But here's what he told me. He said he believes this a ton. He was the president of the Denver OB/GYN Society, the president of his group. He gave me about 7 presidents. I told him I'm not president of my household. We'll get to that as well. But he went through all this with me. He's like, but I believe in this so strongly. We followed our patients for 1 year. We didn't have time for this. I understood the importance. We sent everyone to a genetic counselor in my group. And guess what percent of my patients went? I said, I have no idea. He's like 8%. And that's me being in practice for 38 years, being the president of this, the president of that. So how many patients go in general? So we decided we were going to set up a protocol in our office. We started testing, and we've made a world of difference with this. And I was like, I mean, don't listen to me. I'm not the past president of my household. Listen to Dr. Kirkpatrick. It was great. Try the veal. I'm out. It was great. Now, the bad part about this is this is going to tell you how dumb I am if you didn't get it before. So I went home and told my wife that past president, I'm not past president of my household. I said, I'm the vice president. I joked. She's like, you're not the vice president. She told me I was chief of fundraising. And a lot of people take that the wrong way, but I was super happy I was the chief. So I told my boys. Next slide, please. Now, I will tell you, going back to the other slide, you don't have to go back, but that they did reaffirm their statement, came out with a much stronger statement later on, which was great. So when they came out with a much stronger statement later on, that kind of changed people's views. U.S. Preventive Task Force came out with something. This is 2013. If you look at this from the U.S. Preventive Task Force, grade A, prevention healthcare services, is high blood pressure, right? B, obesity, depression, diabetes, and they added hereditary breast and ovarian testing. That's unbelievable. That's a huge statement in 2013 that came out. It said genetic counseling about BRCA may be done to trained health professionals, including primary care docs. That's a huge statement right there. U.S. Preventive Task Force doesn't care about costs or anything else. What they look at is, are you making a difference in outcome in patients' life? I didn't know a lot of this beforehand, and obviously you do. Next slide. Committee opinion. This just says, this again, these are all the ACOG criteria here. Protocols and checklists improve outcomes, and they do. Someone has an abnormal Pap, we all grab our phone, we look for the ASCCP guidelines, which we do, we pull it up. You have someone with recurrent pregnancy loss, we have set protocols. We have set protocols for infertility we use. And what's the set protocol we have for hereditary cancer genetics? Most of us don't. So again, we have to change that to make a difference. You think about timeouts, and that's made a big difference in the OR because everyone's on the same page. Again, it's very listed. It makes a huge difference. Next slide. Again, so this is saying, this is committee opinion, 2015, reaffirmed again, family history plays an important role. We know that all patients should receive a family history evaluation as a screening tool. It should be done and updated regularly, not annually, not just for annuals, but on a regular basis. Next slide. So again, ACOG says standard of care that we're qualified to do this. We need to implement a process. It supports this as a routine practice. Next slide. So again, this is just saying that, yes, we can do this, and there should be no limitation on what we can do. I know the genetic world initially, when it came out, didn't want anyone doing this. And the way it was presented initially was kind of rough as well, that just every provider should just do this. No, I think there's both sides that has to be educated. The goal is to educate your patients, give them the information they need, provide the care they need, and make a difference. Next slide. So again, this is just talking about panel testing, going to just BRCA1 and 2 and Lynch. We've now added on genes for Lynch and multiple other genes. There's probably about 35, 40 genes now that have NCCN guidelines for. This is supported by everyone. It's cost effective, improved efficacy, and better assurance for patients. Next slide. So I use a family history questionnaire. There's tons out there. There's tablets now. It can go right into your system. I've seen them on different healthcare systems. This should not be hard like it used to be. How I do it in my office, there's a pink sheet when you walk in. I'm not that smart. Pink and breast cancer, I remember that. It says, we care about cancer. You fill it out, bring it back to me. That's it. No one else needs to see it. I used to have my nurses, my MAs, look at this, figure it out. Who knows your family history? Just you. My wait time is about 25, 30 minutes. Some people say, oh, that's not bad. Some people say, that's terrible. I don't know. That's what it is. In 25 minutes, you can answer 15 questions. And again, have you ever asked someone if they're Jewish as an icebreaker? It's not great, but it makes a huge difference for these patients or other high-risk populations. And again, you're not going to ask that. And if you don't believe that's uncomfortable, ask the first person you meet tomorrow that and see how it goes and let me know. So again, that's why I just put it on paper. It's so much easier. If we went around the room right now, what are the Lynch syndrome cancers? It's listed for you. It's listed for the patient. As providers, I don't know that we'd get all those, but it makes a huge difference. And again, using a family history questionnaire, GOGS says will improve your efficacy 50 to 70%. I didn't believe that when I first started, so I did it for a month in our office, and we weren't 50 to 70%. We were just 68% of the patients we missed. So I went back to using a screener. Next slide. So again, this is to say, who do we evaluate for risk? Personal history, breast cancer, any age, if you've had it, ovarian cancer, metastatic prostate, pancreatic, Jewish population with a history of cancer. First or secondary relatives, and again, they're listed for you. Breast cancer under 50, 2 breast cancers, 3 breast cancers, ovarian, metastatic prostate, pancreatic, any age, or male breast cancer. Male breast cancer rates a huge flag. That's about a 10% risk. That's the same as ovarian cancer. Again, if you have mutation in your family, Jewish with a personal history as well. Next one, please. Lynch syndrome, personal history. That's okay. You can go back one. Lynch syndrome, again, uterine cancer less than 65. Again, that's been dropped as well. Colorectal cancer less than 65. First degree relative less than 50. 3 or more relatives. And again, the Lynch syndrome cancers are listed right there for you. Let's go to the next slide. So when you discuss this, ACOG says you have to bring up certain points. And first of all, I have my own written things that I use. You guys are welcome to these. I'm happy to send them to anyone. Discussion of possible outcomes of testing, right? So you got to know if you're positive, negative, you have variance. We go through that with patients. Options for surveillance, chemo prevention, risk-reducing surgery, family, psychological implications. Absolutely. Cost of testing has to be on there. Current legislations, again, they're talking about the GENE Act there. You cannot be discriminated. It's a federal law. You cannot be discriminated against from a health insurance standpoint. People always ask, what about life insurance? Life insurance has no baseline. There's no qualifications that you can use for that. They can discriminate against anything. I've met with Northwestern Mutual and many companies beforehand, and that's pretty much what they'll tell you. That's how we make our money on discrimination. People are like, well, get your life insurance first. They don't ask you if you carry the genes. And when I met with someone at Northwestern Mutual, the guy was great. He's like, it's only about 10 to 17% of this, 24%. He knew every little thing. He's like, if I asked this, I couldn't, my picture would be bigger if I didn't ask it. So I just asked your family history and based everything by that. So again, my whole goal is to keep you alive and to keep you around. That's why we do this. Next one. Informed consent or refusal. Discuss this like you would any other test. It's a diagnostic test that we're making based on abnormal screening. Again, get documentation like we should for everything. Next. So this, I just want to put up, there's 8,000 billion labs that are coming to your office now. All you want to do is ask 5 things. Can the lab find mutations? Can you classify the mutations? Are they looking at variants? Can you report them? Is there published data to support this? And does the lab support you? I would always ask those questions. You know, I work on the value analysis committee in our hospital. Before you come in, you have to show us that you're financially suitable. You have to give me studies to say, here's why we're going to do this and why we're going to go forward. And if you can't do that, we wouldn't go forward with the product. So again, there's no difference there. Ask the same thing from those labs. Next slide. All right, we're going to skip this one. All right, so again, you can skip that one too. We just talked about that, products, physician resources. And that's all I have for you guys. So I would tell you this. First off, I appreciate everyone's time. This is something that's very important, should be very important to all of us, and it certainly makes a difference in people's lives. My whole goal, I tell my kids, I want you to do 3 things in life. Find your passion, go after that, work hard, and make a difference. other things I do, it's great. I love my incontinence, urogynecology. I love minimally invasive surgery and robotics. That's great, but no one dies from leaking urine. But when I go through this with patients, this is my most satisfying thing done. Even when I have positives that come back, right? And I brought up Lori. You have Lori in your office. You have multiple people. All of us could name 5 or 10 people with cancer right now in our practice and what they're going through, and if you can make a difference in their lives. So again, family has to come first. Family history is the only symptom these patients have, right? They don't come in with a lump, bump. They're not bleeding, bruising, or anything else. They come in with their family history and treat that appropriately. That's one of my favorite pictures there, except right now I'm the smallest guy in my family, which is not great, and I'm 6'3", but what can you do? Let's go to the next one. All right, you can skip down to the last one. Skip one more. That's great. If you guys don't have a little girl in your life, you need to get one for sure, and that's how I'm going to end this. So I appreciate your time. I'm happy to answer any questions I can. Like I said, I've been doing this for about 20 years. It's just made sense to me. It's got so much easier to test. When I initially tested, there were a ton of barriers we had to go through. Now it's very straightforward. And like I said, it's very gratifying to me, and it makes a huge difference in patients' life. So thank you, guys.
Wow, thank you so much, Dr. Brodsky. That was spectacular, and I very much enjoyed your narrative, but also all your family photos. They're beautiful.
Thank you.
You have, this was an interesting talk, as we can see from the chat. There are many questions in the chat, and I want to invite folks, if they're comfortable, to unmute themselves and ask their questions themselves. Dr. Green, you had 2 questions. If you are available and can unmute, go ahead.
Apologize, I put food in my mouth as soon as you asked me about that. Can you hear me?
Yep.
Okay, sorry about that. Wonderful to have you. Thank you for the lecture. Absolutely wonderful information. I do already provide testing for patients. I'm the director of our high-risk breast clinic. One question was any suggestions on how to keep updated with this information, because it is constantly changing. I do train my residents with regards to the NCCN guidelines, and that's definitely a wonderful resource, but anything else that you would suggest? And then secondly, any suggestions for those patients without insurance? We do have a grant that covers our testing, but it's difficult just to keep up with that on a year-to-year basis. So any suggestions on those?
As far as guidelines, NCCN guideline, U.S. Preventive Task Force guidelines do change, and they usually come out with them every year. So I just subscribe to those. Then I get those, and I just kind of change those on my sheet, because you're absolutely right. I will tell you, usually wait about a year to update those, which may sound terrible, but usually insurance takes about 6 months to a year before they cover them. So if I changed right away when like metastatic prostate came on and just prostate, if you added it, then it wouldn't change right away and insurance didn't cover it, then patients got a little frustrated. So usually wait about 6 months to a year before I add them on as well. And as far as the other one, as far as getting funding, most of the companies that I work with, again, for patients who are underinsured, and it's now, I think it's 3 times, I forget what it is, the lowest, and I can give you numbers in Ohio and Michigan, but it's pretty low. 3 times the low socioeconomic status are testing for free. So overall, I think about 30% of the patients we see will pay. For my practice, I can tell you this, about 85 to 90% of my patients pay zero, which is great. But we've also had funding just as well, like you have as well. We do a high-risk breast clinic too, and it's made a huge difference. But most of the companies will work with patients who are underinsured or uninsured, so there's very few costs. Our average last year was $27 out of pocket. I always keep track of that, obviously, because if you're going to talk in this, I think you need to have results as well.
Wonderful, thank you.
So I appreciate you doing what you do, and obviously,
Dr. Perry, are you available to unmute and ask your question?
Yes, I am.
Thank you, Dr.
Thank you, Dr. Brodsky. That was fabulous. And I think it was so, it's utilizable on all levels in terms of what we do. I had a question, as it has been my practice, particularly over the past few years, as we expand our panels and what we're able to test for, to recommend people that have had previous panels and testing done, consider updating those panels, and maybe encouraging their family members to update those panels. Do you have a general recommendation as to how often that should be done?
So update testing if patients have had testing prior to 2014, it was just BRCA 1 and 2 and Lynch Syndrome. So any of those patients will get update testing. They're almost always for free. So those will be done. So, and again, most of the companies, if they come out with a new panel or add new genes, will test patients for free. But I would encourage you to talk to your representatives from whatever labs you're using or working with and find that out. But I've not had an issue with anyone getting a cost who's tested prior to 2014. I've been doing this since like 2001 religiously, and it's made a huge difference. And like I said, those patients, it's great for their families. I've also had variants which have been reclassified, and I'll get that result. I've only had about 2 that have been reclassified as positive, 90-some% are reclassified as negative. But that's a big deal when I tell people looking at companies, because if they're not doing, variants and reclassifying those, I have a hard time using those companies because I've seen that. And I've seen false positives and false negatives, as probably most of us have. So again, you want to make sure you're getting good values out of your labs as well. But I hope that answers your question for you. So before 2014, panel came testing around 2015.
Thank you.
Thank you. I appreciate it very much.
Oops. Sorry. Dr. Zertucci, would you like to ask your question?
Sure. Thanks, Dr. Kotke. This was an excellent presentation. As a busy private practitioner, this is something that I really strive to incorporate into my practice, but I also struggle, I think, with some of the logistics surrounding it. And so I'm really interested in hearing a little bit more about some of your office protocols, particularly in regards to results and how you cover those with a patient, whether it's positive or negative. Do you bring them back in person? Do you talk to them on the phone? And then particularly for patients that do have a strong family history of any type of cancer and end up screening negative, obviously they are continue to be at increased risk, but I think the guidelines are kind of less clearly established about ongoing screening for them in terms of starting earlier, increased frequency, et cetera. So how do you counsel your patients about that? And is that something that you manage yourself or rope in other specialists such as gyn-onc or breast, et cetera? Thank you so much. Wonderful talk.
No, it's my pleasure. Thank you. I appreciate that. So my protocol is pretty easy. I've changed my protocol. I think because I've made a ton of mistakes. My dad always told me, if you learn from your mistakes, that's good. If you learn from someone else's mistakes, that's great. You're a genius. So I'll just tell you, I've made tons of mistakes with this. I tested 2 people my first year out and handed more brochures out than anyone in the country. Then I realized brochures weren't saving lives. I got away from a family history questionnaire, and that didn't work. I was missing about 70%. So when you walk in my office, new patient, existing patient, anyone who comes in outside of my routine of ease, you get a pink sheet, you fill it out, 15 questions. I get 1 yes, you test. On the top, it says, have you been tested before? Is there a family mutation? So I don't want to ask the patients who have already tested, have you been through this? They've already been tested. So we go through that initially, they bring it back to me. It's the first thing I look at. I don't care if you come in for vaginitis, UTI. Again, people don't die from those things. I start with this. You're my high stress patient for this. Here's what I recommend. Again, do you have time for cancers or one thing I can do for your family? Yes, I want that done. Here's what we're going to do. And I see you back in 1 month. I see everyone back in 1 month. And I'll tell you why, because like I said, 50 to 70% of the time, this is making a difference. And that's great. High risk negatives, like you said, there's protocols they can set up that's covered by their insurance for breast MRI. And think about this. Mammography is great. Screening tests, 40%. MRI is much better. It's almost 70%. But if you do mammogram, MRI 6 months later, clinical breast exam, I usually do one. I send in a breast surgeon I work with to do one. Now your sensitivity goes up to about 94%. So that will tell you you'll pick up cancer earlier. Survival is much better. That's great. So again, I bring everyone back and I tell them that. If you're the true negative that comes back, that's great. Your family doesn't need to be tested. I explain that as to why, as long as it's not on dad's side as well. And again, obviously we see a lot of divorced, separated families, so they still need to be tested. I go through that with them as well. And that's great. So I think it's going to make a huge difference for those patients. So I see everyone
my
back in a
little
month.
table. Samantha's
Right.
at the big table. I'm at the little table. Okay. I'm leaving everything that's mine here.
Thank you. Dr. Royak, are you able to ask your question live?
Yes, and thank you for that excellent presentation. I probably learned more than anyone because I'm not in this game anymore, maternal fetal only. The question I have for you is, we have apps for STIs and apps for patients at high risk and delivery timing. Is there anything that's reliable, up to date, available in a busy private practice to rely upon?
So I love the way you brought that up, because there are certain apps, but I like how you said reliable and accurate. I've seen multiple apps. There hasn't been an app that I've loved that's made sense, just like you said, with STIs and looking up CDC or looking at abnormal pap smears. It makes it very easy. Or even from MFM, I look for my growth restriction or my diabetics. It's very easy. It's listed for you. Calculators for VBACs. So I don't think there's anything that's that good that I've seen that I love that I would say I would use this, because there hasn't been. And again, the problem with a lot of those apps is you have to put in all the information, and always, depending on if they're going to do a risk score, use a hierarchic method, which most companies do now. So for your high risk negatives, you'd have to put all that in there as well and find out the ages of these different things. So to me, in my end, I identify you're at risk. I kind of let the companies deal with that and try and find out with the age and family history. Again, the family history I have in front of me, the ages the patients put down, but to put all that in and calculate all that, I used to do that. It was just very time consuming. And now, since all the companies do it, it makes it much easier. So I don't have a reliable app. There may be one out there, but not that I've seen. So I guess that's what I would tell you to start. And it is unfortunate.
Thank you very much.
No, thank you. I appreciate it.
Dr. Scott just put another question into the chat. Do you retest patients who screen negative for family history?
I retest patients or rescreen patients?
I'm not sure. Dr. Scott, do you want to unmute and clarify the question?
It was probably rescreen.
Yes, rescreen. Myriad and some of the other companies are recommending screening every patient every year with the pink sheet. Is there any recommendation once someone is screened negative, would you screen them again in the future, in the near future?
So absolutely. So rescreening, because no one's family history gets better. So I've had patients like, it's all negative. Well, it's not going to take you long. I always tell them, if they fight with my office staff, just bring in Dr. Brodsky to go through with you, which happens very rarely, because family histories change. Like my grandma passed last year at 106. That's half my family that's Jewish. If she came back positive at 106, that'd make a huge difference for my family. And we don't have any cancers in my family. So rescreening, absolutely. Again, ACOG says do it on a regular basis. So if my patients haven't been in, a lot of our patients don't just come in yearlies. Now they know their pap smears are 3 to 5 years. So they say do it on a regular basis. If it's been over 3 to 5 months, I have them do the screening test again. I think your patients know it. But I got to tell you, most of my patients are super happy to see this. My new patients, like, why didn't I get this before? I've seen multiple other people. My family history hasn't changed, but people's family history do change, is why they recommend rescreening, as does ACOG. So hopefully that answers for you, Dr. Scott.
Yes, it does. Thank you. Nice talking to you again.
That's nice to talk to you as well.
I have a thought. This is actually my own question. One of the things that you said during your talk that I will take away, that I really appreciated, is how you look at this as a vital sign. And I thought that really struck home. For me, I take care of a lot of adolescent patients. And I'm just curious if you can talk about how adolescents, particularly minor patients, how that interplays with the recommendations on testing when you're talking about minors.
Sure. So coming through that with minors, again, depending what age, how we look at things, we just had a contraceptive talk, and how ACOG looks at things, start with LARCs, better compliance, long-term, that's wonderful. Unless someone's had, obviously, family history of ovarian cancer, then you want to be on birth control pills for 5 years, and you get a 70% lifetime reduction in ovarian cancer. So I think that's one huge aspect of that. As far as when to test adolescents, again, the recommendations I've seen all over, I don't start till 21. Again, I'll talk to them earlier about birth control pills versus using other forms of contraception. But, obviously, and don't forget about breast cancer. I always tell people this: for breast cancer, it's not just so much that it's gene and it's screening. Diet makes a huge effect. Decreasing fats, red meats, exercise, huge things. You can decrease alcohol. Again, decreasing breast cancer. I've seen studies as far as 30 to 50% decrease based on, again, modifiable factors. That's great. So I would say, to me, 21 to 25 is the recommendations I would use. Again, I've seen guidelines. You should start at 18. I think that's too young. I don't think it's going to change too much. Again, when we start screening for these patients, again, we used to do mammograms at age 25. Now we don't do mammograms, we do MRIs at 25 and start, again, mammograms at age 30 just from the radiation amount. So I would start it earlier just to talk to them and so they know about it. But again, from an anxiety stress level, I've had moms come in, I want to wait till they're 25. I've had people tell me I want to wait till they have their kids. Well, that can't be the case necessarily, and I go through that with them. But again, it has to be a decision they're comfortable with. But again, our goals are not making decisions for them. It's educating them, giving them information, let them make their decisions. So, but that's what I would tell you my guidelines would be.
That's really helpful.